All right, young ones, here we go. We're going to talk a little bit more about EKG. I'm going to move relatively quickly through this, so bear with me. Feel free to go back and look at things often. There's some review in here that I'll move quickly through. And then when we come together and work in lab, be sure to have whatever questions you have or clarifications that you need as we go through this. I might recommend that you have a pad of paper or something where you can jot down questions as we go with anything that comes up with here. But without further ado, let's share screen. Okay, we're going to start first here with junctional rhythms. Junctional rhythms have various parts of importance here that we're going to hit that can be somewhat confusing when we start comparing them to ventricular rhythms and atrial rhythms, but let's see what we can do here. First of all, when we talk about junctional rhythms, we're talking about the AV node and the bundle of His primarily. So these are some pictures from some textbooks that you have or that you should have, so you can refer to the anatomy on these things. I want to just remind you that the gap junctions within the cardiac cells allow conduction to go any direction. So with the AV node, even though our directional travel is supposed to be going from the atria to the ventricles, if there is a conduction that initiates within the AV node, it'll go both directions through the ventricles and through the atria. So when the AV node fires, realize that you're going to see the QRS complex, which is a representation of ventricular depolarization, but you may also see the atrial depolarization as well. And depending on where in the AV node the initial firing begins determines if we see a P wave before the QRS or after the QRS. So if we're in the early stages at the top end of the AV node, then it's likely that what we're going to see is an antegrade P wave that comes before the QRS complex as the signal is delayed through the rest of the AV node. If the signal is at the tail end of the AV node, closer to the ventricles, then you'll see a QRS complex immediately as the signal is leaving the AV node. And then the P wave will come retrograde, will come after the QRS, because as the signal is traveling towards the atria, it's going through the delay process within the AV node. So in either case, our PR interval is short, meaning the distance between the QRS complex and the P wave, or the P wave and the QRS complex, will be shorter than normal. So keep that in mind. And we'll talk about two intervals here. We've got a PR interval and an RP interval. The RP interval is in reference to the fact that the QRS complex happened first and then the P wave. So it's from the beginning of the QRS complex to the beginning of the T wave, to the beginning of the retrograde P wave, in the same way that the PR interval is from the beginning of the P wave to the beginning of the QRS complex. So basically that's telling us how long the delay is in the AV node. And that's really what's important about the PR interval, and in this case, the RP interval, is the amount of time that the signal is spent in the AV node. So basically, we've got a variety of things we can see in relation to P wave activity within a junctional rhythm. The P wave could come just before, but very close to the QRS complex. It could be mixed into the middle of the QRS complex, and therefore we don't see it because it's hidden, or it can come retrograde after the QRS complex. Those are all possibilities. In junctional rhythms, if the junctional rhythm is a normal junctional rhythm coming from the AV node with the inherent firing of the AV node, then we will have a junctional rate of 40 to 60 beats per minute. If it's going faster than 60 beats per minute, we call it accelerated. And if it moves faster than 100, then we call it tachycardia. There's that window of time between the 60 and 100 beats per minute that is faster than what the AV node would fire inherently on its own, but it isn't a tachycardia. So again, we call that accelerated junctional. So junctional rhythms, accelerated junctional rhythms, and junctional tachycardias. And I will split up junctional tachycardias in a minute here as well. So just like we had PACs, we also have PJCs. PJCs are junctional depolarizations that come prior to when they're supposed to. They meet all the same definitions that we had for a PAC, except in this case, it's initiated by the AV node and not from a P wave. So when you see a PJC, the QRS complex should look just like all the other QRS complexes, but you won't find a P wave that's initiating it. P waves will be potentially in the same manner that we just discussed. So they might be a retrograde P wave or an antigrade P wave, or it might be a hidden P wave, but it'll be tucked up against the QRS complex, and it'll be inverted in leads 2, 3, and AVF. And you won't find it hidden in the T wave like we potentially see with the PACs. Really, it's the same information that you learned with PACs, and that these complexes are coming sooner than expected. For whatever reason, the AV node has an increased automaticity, often because of sympathetic activity. Usually it's associated with non-compensatory pauses, but you can have either one that occur. And they can be in combinations or they can be single. So when I say associated with non-compensatory pauses, that's because it's coming at a time frame that the junction usually gets control over the SA node during the depolarization, its own depolarization, and therefore the next beat comes out of time. And so an example of a PJC. When you're looking to try to determine PACs or PJCs, look at that T wave before it, right? If the T wave looks absolutely normal and you don't see a P wave anywhere else, then you've got a PJC. And the P wave should be inverted in 2, 3, and AVF. And of course, the PR intervals or the RP interval should be very short, less than 0.12. If all of those characteristics are there, you've got a PJC instead of a PAC. So looking here in the first cartoon, you don't see a P wave anywhere, and therefore we can call it a PJC. And in the second cartoon, you note that there's a difference in the T wave, just like we've discussed in the past. So because you see that difference in the T wave, you would note that there's a buried P wave, and therefore this is not a PJC, but a PAC in the second cartoon. Noting aberrantly conducted PJCs. Aberrantly conducted PJC means there is something that has blocked the signal after it has left the bundle of His, and it's starting to travel down the bundle branches. One of the bundle branches gets blocked for some reason, and the signal has to go cell to cell in the ventricles. This is going to cause the QRS complex to widen out. It's possible that that happens obviously through the entire rhythm, but it's also possible that it just happens on the PJC. It's possible that something that is causing the PJC to fire early also has an effect of causing an aberrancy of some sort. So trying to determine the difference between a PJC and a PVC that is aberrantly conducted, there's a couple things you can look for. First of all, PJCs will always be coming from the AV node. Because they're coming from the AV node, they at least will initially travel down the fast autorhythmic pathway prior to it getting to the aberrancy. So for example, if we have a little bit of an aberrancy in the right bundle branch, the left bundle branch wouldn't have the aberrancy, and therefore we would see a normal conduction through the left side, but not through the right. What that means is that the first part of the QRS complex of the aberrant PJC will always match the first part of the regular QRS complex. The first few milliseconds will be the same. In other words, when you look at it, you'll see the start of the QRS complex of the PJC that's aberrantly conducted will be identical to the start of the QRS complex of every other QRS complex. Now, it's harder to say this in only one lead. So if you have a 12 lead and you see the PJC in multiple 12 leads, and the first part of the aberrantly conducted PJC is the same as other QRS complexes in that lead, and multiple leads show that, then you will have a aberrantly conducted PJC. Depending on where the block is that's creating the aberrancy and how close that is to the AV node will determine how much of the beginning of the QRS complex is the same. So looking over here on the right-hand side at these two cartoons, pretend for a moment that this top one is one of the leads and this bottom one is a different lead at the same time in the same patient. You'll notice that this PJC right here begins its conduction in the same way that the normal QRS complex began its conduction. And then looking in another lead, you see that the normal QRS started with a small Q wave, and you see that the aberrant conducted PJC also starts as an initial Q wave and ends up being a QS wave altogether. So because this is in multiple leads with the direction of the PJC happening in the same initial direction as the QRS complex preceding it, you would say that this aberrantly conducted PJC is in fact a PJC and not a PVC. And then there's all kinds of etiology for this that is the same as all the etiologies that we saw with the PACs as well. Junctional escape beats, again, an escape beat is one that comes after. So a junctional escape beat, anytime you have a blank spot, that could be because of a sinus block or a sinus pause. And then the junction is what comes back first before anything else happens. So that junctional beat that came back is the AV node trying to prevent the heart from going into cardiac standstill. And then it's just a simple beat if after that beat, the SA node starts firing again and we get back into a normal rhythm of some sort. So a junctional escape beat is a beat that happens after it's supposed to, and it's trying to prevent cardiac standstill. Increased vagal tone is something that can create that. The same things that we talked about before that might create a sinus block or a sinus pause. So some sort of a pathology within the SA node or a heart block, which we'll talk about in the next video segment. The junctional escape rhythm is anytime that escape beat ends up becoming the rhythm rather than going back to some sort of a normal rhythm. The normal rate is 40 to 60 beats per minute, and you see all of the characteristics of the junction firing. So either no P wave because it's hidden, or a antigrade or retrograde P wave with short PR or RP intervals. So in this cartoon, you're seeing a rhythm that's initiated from the atria here that eventually goes into some level of a block or a pause. And again, the AV node is trying to prevent the cardiac standstill, so it takes up the firing with a junctional escape beat, and that junctional escape beat ends up potentially becoming the rhythm, or the rhythm will go back just depending on what ultimately happens. But that initial junctional escape complex can initiate into a junctional rhythm. So if we have 3 consecutive complexes that are all junctional escape complexes, we would then call that a junctional escape rhythm of some sort. And the usual rate again is 40 to 60 beats per minute. The etiology of that, often SA node problems to begin with will lead to it. If we have an AV dissociation where the atria and the ventricles are not coordinated, then the junctional escape can be the ventricular activity, can lead to the ventricular activity. Anything we do to increase parasympathetic activity, or anything that we do that slows conduction in the AV node, digoxin, beta blockers, calcium channel blockers, especially for Apamil, are all ones that tend to do that, or some other pathology that you see there are things that can lead to a junctional escape rhythm. If our junctional escape rhythm starts moving at a rate of that's a higher than 60 but less than 100, then we call it accelerated junctional rhythm. All the rest of the characteristics are the same as junctional rhythm. The tachycardia happens when it's over 100. The rates of a junctional rhythm that exceed 140 beats per minute is something that we usually refer to as AV nodal reentry tachycardia, which I'm going to talk about in just a moment. So really the definitions that we have here, 40 to 60 would be a junctional rhythm, 60 to 100 would be accelerated junctional rhythm, 100 to 130 would be junctional tachycardia, over 140 would be AVNRT, which I'm going to talk about in a minute, and anything between 130 and 140 we might refer to as either junctional tach or AVNRT. It's up in the air. AVNRT is a specific anatomic issue, and we'll kind of see the difference between both of those. So again, accelerated junctional rhythms are junctional rhythms that are traveling between 60 and 100 beats per minute. Realize that retrograde P waves, which will be inverted in leads 2, 3, and AVF, can sometimes make it look like an S wave, or can make an S wave look like it is slurred or extended in some fashion. So just note that, and that can make the measurement of a QRS complex even more challenging. So do be aware that if you have a junctional rhythm, you have to consider a retrograde P wave, and that retrograde P wave would not be part of the QRS complex, but it is a fused wave right there, where you're seeing the tail end of the QRS complex fuse with the P wave that's happening in the atria. It can also create kind of a pseudo R prime wave in some leads. For example, in V1, where the P wave is supposed to be inverted, you're supposed to have a negative P wave in lead 1. Therefore, an inverted P wave would look upright in V1, and that upright wave in V1 that is retrograde can make it look like there is a R prime wave in that lead. So again, just be discriminating when you're starting to look at these waves to see what is a P wave versus a QRS complex. Heart disease and surgeries, digitalis toxicities, and electrolyte disorders are all things that can lead to accelerating a junctional rhythm. Okay, so again, in terms of definitions, a junctional rhythm traveling 40 to 60 beats per minute is what we call a junctional rhythm. One that's traveling 60 to 100, we call it accelerated. Then we have some definitions. If it's greater than 100, so if it's between 100 and 130, we would refer to it as junctional tachycardia. If it's over 140, then we will likely be calling it AV nodal reentry tachycardia, AVNRT. And with AVNRT, it's an anatomic issue that we'll talk about. And then again, there's that gray area between 130 and 140 beats per minute that can be referred to as either junctional tach or AVNRT. And the only way we'd be able to kind of tell that difference is if we saw another strip. If at any point in time their heart rate was above 140, then when we saw the strip between 130 and 140, we would probably lead to it being AVNRT. And if the strip was never fast, and we did see some slower versions of that tachycardia in the patient at some previous time with them, that we had them, then we might refer to it as junctional tachycardia. So the 130 to 140 range is a kind of a gray area that we have to consider. So AV nodal reentry tachycardia is one that goes about 150 to 250, most commonly between 170 and 220 is what we're looking at. The P waves are again buried or inverted in leads 2, 3, and AVF. And with AV nodal reentry tachycardia, remember I gave you a little illustration of a flutter within the atria. It's very similar in here in the ventricles. Typically, there is all of the atrial pathways will converge prior to the AV node, but in some cases, some people have two pathways that actually enter the AV node. In that situation, one of them tends to have kind of a faster conduction rate, and one of them has a slower conduction rate. And so normally the AV node is depolarized by that faster, pardon me, by that faster rate. And so, or by that faster conduction zone. So that's something to consider. So when we see that, oftentimes the conduction is getting to the AV node through that faster conduction, and the slower conduction, it's traveling through there, but it doesn't actually complete the conduction all the way to the AV node. And instead, the AV node will come back and finish that repolarization. So in this cartoon, consider this large area down here, the AV node. The atria is over here to your left, traveling down. The AV node is going to be depolarized by this faster conduction. As the conduction is traveling through this slower area, the AV node would start its depolarization and then pass back up through this area, and then they would cancel out in the middle, and it would not cause any problems. So it looks something like what you see here. And this would just end up canceling out right here, and we would never know it. We would never know anything else. Sometimes, however, if that fast conduction pathway has some sort of a blockage that is transient, then what'll happen is the AV node would then become depolarized by this slow conduction and would start moving back up that fast conduction area. Unfortunately, as it starts moving back up that fast conduction area, if this blockage was transient and it is gone after that, then this pathway up here could be ready to be depolarized again. If it's ready to be depolarized, it'll get depolarized by what this AV node is sending back up. As it travels up this direction, this slow pathway will also already be ready to fire again. Its refractory period will be done. And so we will get into a cycle right here of the pathway coming up and then back down the slow pathway. And then we're in a cycle that's happening right here that is causing the AV node to continually be depolarized by this cycling that we see right here. The pathways are different with their own properties, and that's why this can happen. And again, this is just what I showed you with the illustration of the water. Sometimes it'll be initiated by, often it'll be initiated by a PAC. A PAC will come and fire, and when that PAC fires, it mixes up the refractory periods that are happening in these areas and creates the opportunity for that PAC to then move and get control of this particular cycling within the AV node. And because that PAC fired, the PAC doesn't control it after that, because the PAC initiated and mixed up the way that things were firing in here. It creates the ability for the AV node to get into this cycling that we see with AV nodal reentry tachycardia. Oftentimes the slow pathway has a faster repolarization, and the fast pathway has a slower repolarization, which means when the PAC hits, the PAC makes it so that the slow pathway is done with its refractory pretty quickly, but the fast pathway is still in its refractory when the next signal comes down. And that means that the signal gets through the slow pathway before the fast pathway on that next beat. And because that next beat gets through it faster on the slow pathway, the AV node is then the thing that is now depolarizing the fast pathway. The fast pathway redepolarizes the slow pathway back to the AV node, and so on. And we are in AV nodal reentry tachycardia at that point. Okay. So when you're looking at the AV nodal reentry tachycardia, there's often you'll often note that the PAC that you had kind of a long PR interval associated with it beforehand. So that's, if you ever see it initiate, that's one way that you can see that that initiated the AVNRT. And oftentimes there will be a pseudo S wave in the AVNRT. There'll be a retrograde P wave. So look for a pseudo S wave that is close to the QRS complex, or an inverted P wave that's close to the QRS complex. So the criteria here, we have a regular rhythm. It might be a little bit irregular at the onset, so just keep that in mind, but it gets into a regular rhythm. It's between 140 and 250 beats per minute. And the P waves are often buried, and they can create these pseudo S and or pseudo R prime complexes that are pretty close to the AVNRT. So a junctional tachycardia that is fast, above 140 beats per minute, with those S waves that are pseudo S waves or R prime waves that are tucked in really close to the QRS complex. And we would call it AVNRT, not just junctional tachycardia. Some of it's idiopathic. It just, I mean, if a PAC causes it, it's not a disease process that led to it. So, so there's that. And then AVNRT can also be caused anytime we have that dual pathway into the AV junction, which is really what's causing it. And it's often found in patients that do not have other structural heart disease. So in other words, these people do not necessarily have any sort of heart disease that led to this arrhythmia. It's more anatomic. So what you see here in the first cartoon, again, is a fast junctional rhythm that has that pseudo S wave before it. And at the bottom, you have this fast wave that has a what looks like an R prime attached to it. This right here being the T wave, and again, this right here being the T wave. And you note that this is not just an SVT, and you can tell the difference because you do see these little P waves tucked into the QRS complex all over here. So you can call this AVNRT and not just an SVT. AV reentry tachycardia. I understand the names are close and that might lead to some confusion, but AV nodal reentry tachycardia, AVNRT, which we just talked about, is related to reentry into the AV node. AV reentry tachycardia, atrioventricular reentry tachycardia, is a term that is talking about the same kind of a circular pattern that I just described in AVNRT, except it's not solely with the AV node, it's with an accessory bypass track. So the exact same discussion that we just had related to a slow pathway and a fast pathway in AVNRT is what we have here as well, where the slow pathway is the AV node itself and the fast pathway is the accessory bypass track, like what you would find in WPW or something to that effect. So instead of at the AV node, we're now talking between the atria and ventricles together. So AV nodal reentry tachycardia, AVRT, it's a fast one, 140 to 250, which is similar to the AVNRT, but do realize this can actually be much higher. There are two versions of it. And in the more severe version, it can be going very, very quickly, almost up to 300. And that's obviously very detrimental to the patient. So here what we have is the same kind of situation where you have a slow pathway and a fast pathway, where the slow pathway here is the AV node itself, The fast pathway is the accessory bypass track. And you might remember from a previous time that I talked, the AV node obviously is delaying the signal. So it's slowing the conduction to give the atria time to finish its depolarization before it spreads to the ventricles. But the fast pathway, this accessory bypass track, isn't nodal tissue. It's just autorhythmic cells. So the pathway can get through from the atria to the ventricles without any delay at all. You might think of it as a backdoor to the ventricles. Because of that, the impulse is traveling down both the AV node and through the accessory pathway. And as the impulse goes through the accessory pathway, everything is going cell to cell. Because of that, you see the formation of a delta wave, which is a slight little curving up into the QRS complex. You might remember that I drew that a few days ago. It also means that it makes it seem as if the PR interval is shortened because it looks like the QRS complex is starting closer to the P wave. But after the physiologic block within the AV node is done, then the signal is right back into the autorhythmic cells and through the Purkinje system. So even though it starts going cell to cell because of the accessory bypass track, as it starts going cell to cell, eventually the AV node completes its delay and everything else happens as rapidly as normal, which means now the AV node, the QRS complex, because of the AV node, takes over, and the back half of the QRS complex looks normal. So it's the little delta wave at the beginning that we sometimes see. And so you can see it here on this cartoon. You have the P wave followed by this beginning of cell-to-cell transmission within the ventricles, but then you get to the end of when the delay is done and the signal is through the Purkinje fibers, so everything else looks normal and depolarizes properly. And on the cartoon over here, you can see the AV node is currently delaying while this bypass track has allowed the signal through. So it starts going cell to cell, but it's completed in the normal fashion. Wolff-Parkinson's White pattern is one version of this accessory bypass track. The things that we note in it is it's got a seemingly short PR interval, the presence of that delta wave, and this is only seen in slower rhythms. The QRS complexes are greater than 0.12 seconds because of that delta wave. We often will have ST and T wave changes or abnormalities, and then Wolff-Parkinson's White syndrome starts to occur, which when we get into the tachycardias, which you'll learn when we start talking about some of the cardiac stuff as we go through the rest of the paramedic course. There are two possible reentry circuits that can come into play. One of them is where the pathway goes from the atria to the ventricles through the AV node and then back up through the accessory bypass track. So it's this circular pattern that goes through the AV node and up through the accessory pathway. Again, the slow pathway through the AV node and the fast pathway up through the accessory path. The other version of AVRT is where the circuit gets through the accessory pathway first and comes back up through the AV node. So that means it's going through the fast accessory pathway, depolarizing the ventricles cell to cell, eventually getting back up to the AV node, and then going through the AV node into the atria. So that is the second version of it. So the first version is something we call orthodromic AVRT. You're not really going to be asked about that specifically, that name, but I want you to understand the possible differences here. So orthodromic AVRT is where the impulse travels down the AV node in the slow fashion and returns retrogradely up into the accessory pathway and on up into the atria. It is the most common, fortunately, it's the most common form of AVRT because the other form is very detrimental. Rates of between 140 and 250 beats per minute. The QRS complexes tend to be narrow and under 0.12 seconds because as you start moving faster and the sympathetic system starts to engage, remember that in the AV node, it speeds the conduction through the AV node. So there really isn't time for that delta wave to form before the QRS complex is initiated. There is kind of a prolonged R to P interval with negative P waves in leads 2, 3, and AVF. And note that that is a prolonged R to P interval. And that is because we're getting into a situation where the P wave starts to become retrograde. We have the signal getting through the AV node, then it rounds out through the ventricles, and then from the ventricles up into the atria. So in this case, the atria gets depolarized after the ventricles. Then it hits the AV node. It goes through the entire depolarization of the atria, cell to cell, eventually getting back to the AV node. And then we've got the delay going on. And now it's going slowly through the AV node. It gets through the AV node. Boom, we have the QRS complex. It circles back up through the accessory bypass tract and then into the back up into the atria to depolarize the atria. So in this particular case, the P wave tends to come after the QRS complex, so it's retrograde, and we end up with a prolonged R to P interval. So in other words, from the beginning of the QRS complex to the beginning of the P wave tends to be a longer period of time, closer to 0.2 or greater. The delta wave is not created in those tachycardias, and it's less dangerous than the other version called antidromic because the AV node is still controlling the rate for the most part. Antidromic AVRT then is a much more dangerous version where we're going down through the accessory bypass tract and then back up through the AV node. The retrograde return is through the AV node. It's less commonly seen. The rates again can be between 140 or 250. However, they can be well over 300 beats per minute as well. The QRS complexes are wide because we're coming through the accessory bypass tract and then having to move cell to cell through the ventricles. As it moves cell to cell through the ventricles, we have a wide QRS complex, then it hits the AV node and then pops up through the AV node into the atria. Again, we have a prolonged R to P interval with P waves that are negative in the inferior leads 2, 3, and AVF. The delta wave is still not created during tachycardia, so we don't see that delta wave. It is much more dangerous than orthodromic because the AV node no longer has any control over the rate. The rate is completely set based on what was initiated by the atria originally. So rates can be much, much faster. Think of something like a flutter happening in the atria and what that return would be as it's going through into the ventricles through the accessory bypass tract. If the atria were firing at 300 beats per minute, because everything is going through that accessory bypass tract, it means the ventricles would be firing at 300 beats per minute. The etiology here is it's only seen, either of the AVRTs, they're only seen in patients that have the accessory bypass tract. And that can either be a concealed conduction or WPW. Concealed conduction is just a way of saying that somebody with an accessory bypass tract doesn't have any electrocardiographic signs of it. So for example, if the signal gets through the AV node efficiently enough, then the signal that's going through the accessory bypass tract doesn't get as extended into the ventricles far enough to actually show up on an EKG. So we don't actually see any of the normal delta waves or anything that is associated with an accessory bypass tract. So the way that we determine that they have this accessory bypass tract in the first place is when they get into one of these AVRTs. So here what you have is in up here in the first cartoon up here at the top, you see that you have the P wave down here towards the nadir of what is going from the S into the T, so the ST segment. If this were AVNRT, this P wave would be, first of all, it would only be inverted, which it's often inverted in this too, but it would be tucked right up against the QRS complex. So because this is moved out compared to the AVNRT, this is showing that it's AVRT instead. And then down here, as in this bottom, and this top one is an orthodromic AVRT. It's a narrow complex QRS. Down here, we have an antidromic AVRT. So it actually is a wide QRS complex. The P wave is found up here as it's moving closer to where the ST segment is leading into the T wave. This right here, these bumps right here are the T waves. You note this is not an SVT because you can clearly see where the P waves are in the T wave, and it is, or right before the T wave. And again, it's got a prolonged R to P interval. So it's not AVNRT. The wide complex, QRS complex, lets you know that it is antidromic AVRT, which is a much more serious condition, of course. And you have to be very concerned about the rate at which it's traveling here, right? We're close to 300. I mean, we're not quite, but if you do the math right, we're almost one big box every single one of these. So we're definitely going well above 250, close to 300 beats per minute. And so when you think about that kind of a speed moving through the ventricles, there's just no way that cardiac output can be maintained. So this is uncontrolled and highly concerning because of the speed. So the speed at which it's going, anytime you have a wide complex tachycardia, that is going faster than about 200, you have to be concerned with whether or not it is antidromic AVRT. And the reason why it's important to think about it being antidromic AVRT and not ventricular tachycardia is because some of the treatments that we have, some of the medications that we might give for tachycardias are not appropriate to give to somebody that has an accessory bypass tract. Any medications that are going to cause a slowing of conduction in the AV node, anything from digitalis to calcium channel blockers, specifically verapamil, to adenosine, to beta blockers, any of these medications that could be given to somebody to take care of a tachycardia, if you give it to somebody that has an accessory bypass tract, you basically just knock out the AV node and everything goes to the accessory bypass tract, and we lose all aspects of AV node control, which can be very dangerous, and it could lead into something more significant. Take, for example, if you have an A flutter, as I mentioned before, that has no AV nodal control at all, then that A flutter moving at 300 means that it's pounding the ventricles at 300 as well. And you could even think something worse here. What if they had AFib? If they have AFib with no control from the AV node, so therefore the AV node is no longer sending and controlling the ventricular depolarization, then that means the AFib is also hammering the accessory bypass tract in a fibrillating way, which can very, very quickly lead to ventricular fibrillation. So it's a pretty serious condition. So again, AVNRT compared to AVRT, you're looking at where the P wave comes. So in the top cartoon, AVNRT, we have that P wave tucked right up against the QRS complex. And in AVRT, the P wave is distanced from the QRS complex. And that's the way you can tell the difference between those two tachycardias, considering they're both traveling very, very quickly, above 140. All right, that one's down. Next up will be a little talk on heart blocks.